Well, good afternoon, everybody. It's a great pleasure to be here with you. My charge is to respond to those very impressive presentations we've just heard. So I'll just maybe pull a number of the points together and try and weave them into something reasonably coherent. I'd like to begin by sharing with you some of the sources I'll be drawing on, some legal sources written by some of the most eminent legal authorities in the United States on end of life and other questions. I think these are a great resource for people, whatever their views on assisted suicide, to familiarize themselves with, and I'll be referring to these three authorities: Professor Yael Kamizar, who wrote this classic article in 1958, Some Non-Religious Views Against Proposed Mercy-Killing Legislation, a chapter in one of the books I edited; Professor Alexander Capron, an analysis of the Oregon Death with Dignity Act; Dr. Neil Gorsuch, as he then was, of course now he's Justice Gorsuch of the Supreme Court, his excellent book, The Future of Assisted Suicide and Euthanasia. And then I might plug my own forthcoming second edition, Euthanasia, Ethics and Public Policy. So I'm going to maybe just, I think, make 7 points fairly briefly. The first one concerns key terms, which was a term that was mentioned. I'm going to talk about voluntary euthanasia, non-voluntary euthanasia, physician-assisted suicide, and I'm going not to talk about physician-assisted death. In most jurisdictions, the criminal law prohibits a doctor from intentionally administering a lethal drug to terminate a patient's life, even to end suffering, and I'll refer to that as voluntary euthanasia, or VE, if the patient requested it, and as non-voluntary euthanasia, NVE, if the patient was incapable of requesting it. Perhaps they had advanced dementia. It's also illegal for a physician intentionally to assist a patient to end his or her life in most jurisdictions, as by prescribing or providing a lethal drug, and I'll call that physician-assisted suicide, or PAS. Now, I avoid the phrase physician-assisted death because it's firstly a euphemism. We're not talking about assisting dying. We're talking about either intentionally ending somebody's life or intentionally helping them to end their own life. And secondly, it's a very ambiguous phrase. Some people use it to refer to euthanasia and physician-assisted suicide, some just physician-assisted suicide, some withholding and withdrawing treatment. So that's why I generally avoid it. Secondly, I'd like to emphasize the legal distinction between PAS and VE and withholding and withdrawing treatment. As you may recall, it was argued before the US Supreme Court in 1997 in support of a claim that there's a constitutional right to PAS, that there's no significant distinction between a physician's withdrawing a life-prolonging treatment at the patient's request and a patient prescribing a lethal drug at the patient's request, and that if the law allowed the former, which it does, it should equally allow the latter. The argument failed. Chief Justice Rehnquist explained the two were widely and reasonably regarded as quite distinct. Everyone was entitled to refuse unwanted treatment, but no one was permitted to assist suicide. The distinction, which was widely recognized and endorsed in the medical profession and in legal tradition, was, he said, important, logical, and rational. He added that a doctor who withdrew or respected a patient's refusal to begin life-sustaining treatment purposefully intended or may have intended only to respect the patient's wishes and to cease futile treatment. The same was true when a doctor administered palliative drugs which hasten death, when the doctor's intent was or may have been only to ease pain. The law had long used the agent's intention to distinguish between two acts with the same result. And the Dutch would agree, intention is key to their definition of euthanasia and physician-assisted suicide. Professor Kamizar has argued it's very important to keep these two different concepts separate, the right to refuse or withdraw treatment and physician-assisted suicide. And similarly, Dr. Gorsuch, as he then was, says the common law's interest in protecting bodily integrity from unwanted physical invasions, this was the interest the Supreme Court in the Cruzan case sought to protect, simply is not at issue in cases covered by the proffered right to consensual assisted suicide or euthanasia. The refusal of care is not logically equivalent to a right to hasten death, and to equate the two is to conflate two very different things, both morally and legally. Thirdly, the basis of the blanket prohibition in most jurisdictions on VE and PAS. In that same case, the Chief Justice cited several state interests justifying laws against PAS, including the preservation of life, the prevention of suicide, avoiding arbitrary, unfair or undue influence, and avoiding any future movement towards euthanasia and other abuses. And he added that the state's interest went beyond protecting the vulnerable from coercion. It extended to protecting disabled and terminally ill people from prejudice, negative inaccurate stereotypes, and societal indifference. Now, Dr. Kim referred to slippery slopes, and I'm going to say a little more about them here. And I'm going to distinguish two kinds of slippery slopes, the first practical or empirical, and the second conceptual or logical. And I draw your attention to a fascinating and classic debate between two very eminent legal scholars, Professor Keown, who was then at the University of Michigan, and Dr. Glanville Williams, who was then at the University of Cambridge, and in fact was one of my old law professors. In their famous debate, it was a debate sparked by a book Professor Williams had published, The Sanctity of Life and the Criminal Law. Professor Keown, as a very young law professor, this was his first article in the Minnesota Law Review, challenged Professor Williams's case for the legalization of euthanasia and physician-assisted suicide, largely on utilitarian grounds. So he was concerned whether effective legal control of these practices was feasible. His first concern was whether it's possible to craft legal safeguards that are sufficiently precise and strict to ensure that PAS or VA are only performed in the sort of hard cases that are widely thought to justify them. Second, he asked, could those safeguards resist logical extension? In his classic law review paper, published 60 years ago this year, Keown saw the debate as between, on the one hand, the need for voluntary euthanasia, which he doubted given advances in palliative care, and on the other hand, the incidence of mistaken abuse and the danger that legal machinery initially designed to kill those who are a nuisance to themselves may someday engulf those who are a nuisance to others. His two key concerns were then about how to ensure the proper application of the criteria for voluntary euthanasia and about the possible extension of those criteria, particularly to permit non-voluntary euthanasia. An example of the former concern was how voluntariness could be determined, especially if psychiatrists weren't involved in the process. As for his concerns about the extension of the criteria, Keown noted that at the first meeting of the Euthanasia Society of America in 1939, the Treasurer explained that its proposed bill was purposely limited to voluntary euthanasia because public opinion wasn't yet ready to accept non-voluntary euthanasia, though the Society hoped eventually to legalize it. Keown also noted that Dr. Williams supported non-voluntary euthanasia in principle in the cases of disabled infants and the elderly with senile dementia, and that Williams's reasons for not extending the law to permit non-voluntary euthanasia were weaker than his reasons for supporting voluntary euthanasia, which Keown regarded as another reason for not legalizing voluntary euthanasia in the first place. It must be said that Dr. Williams, eminent jurist though he was, could produce no cogent answer to Keown's logical argument that if death can benefit a patient who can ask for it, it can equally benefit a patient who is incapable of asking for it. The exchange between these two distinguished legal scholars has served to frame much of the legal debate over the last 60 years. Their debate took place before any jurisdiction had legalized either voluntary euthanasia or physician-assisted suicide. That, of course, has now changed. So let's look at two models for the regulation of voluntary euthanasia or physician-assisted suicide and test their arguments, if you like, against these models. The first question I'm going to ask is, does the Oregon legal model serve to ensure effective legal control? Well, I'm going to turn to the second distinguished jurist I mentioned earlier, Professor Alex Capron, who analysed the Oregon model closely in his article in the Cambridge Quarterly of Healthcare Ethics. And his conclusion was that the safeguards in the Oregon law were largely illusory. He pointed out, for example, that any doctor, including a pathologist like Jack Kevorkian, could qualify as one of the two practitioners under the Act. Any physician in Clyde could set up a practice specialising in physician-assisted suicide and become a magnet for terminally ill people from around the world. The Act did not require the second doctor to be independent of the first, so both could be partners in the same PAS practice. The physician need have no prior knowledge of the patient, how, he asked, could the doctor understand the patient's social circumstances and how changes in those circumstances may have pushed the patient to request PAS. And the likelihood of mistakes in prognosis was large. Predicting the time of death was difficult, and at 6 months, predictions were highly unreliable, involving the grossest kind of guesswork. And we've heard from Dr. Lin how true those kinds of concerns are. And it seems also under laws like Oregon that chronic patients can convert themselves into terminally ill patients by simply refusing life-prolonging medical treatment. So I think the example of the diabetic patient was mentioned earlier in one of the talks. So the person who refuses their insulin, it seems, becomes a terminally ill patient within the language of the Act. Keown went on that the Act safeguards against suicides induced by mental illness or depression were a thin reed. Mental evaluation was required only when one of the physicians, who need not be trained in psychological evaluation, required it. Physicians didn't necessarily have the training to determine whether someone was exercising coercion on the patient or undue influence. And we've heard from Dr. Krim and Dr. Strauss about the difficulties of even defining concepts such as impaired judgment, mental disorder, and voluntariness in this context. So the legislation is rather vague. Moreover, the Act did nothing to ensure, Professor Keown went on, that the patient was acting voluntarily and competently when they actually took the lethal drugs, which might be several months later. Though this was not surprising, he said, as the focus of the legislation was on protecting physicians from legal liability, not on protecting patients against unjustifiable deaths. One may add that the Act relies on self-reporting after the fact by the physician involved. How many cases in Oregon have not been reported? And how accurate are those reports which have been filed? Dr. Gorsuch observed that the Oregon Health Division acknowledged it cannot detect or collect data on issues of non-compliance with any accuracy. He continued that without any means of privately asking doctors about their practices, one might question whether we will ever obtain a true and complete picture of events on the ground. Oregon's regulations, he added, are crafted in ways that make reliable and relevant data and case descriptions difficult to obtain. What role, he asked, was depression as opposed to terminal illness playing in patients' decisions to die in Oregon? Were alternative options, including treatment for depression, being fully presented or presented at all? Were the doctors who prescribed death even knowledgeable about the alternatives? To what extent were family members unduly influencing patient choices and physician evaluations? Did physicians and psychologists have a duty to perform more than a cursory examination? Should they consult the patient's primary care providers and other doctors who may have declined to provide a lethal prescription? Did HMOs have a conflict of interest, given that assisted suicide was undeniably cheaper than continuing care? A key question he underlined concerned the incidence of non-reporting and the accuracy of the reports that were filed. There was, he observed, little chance of such questions, he said, essential to a full understanding of the law's effect and of a thoughtful assessment of its worthiness for emulation elsewhere, being answered any time soon, given the many limitations the law placed on the Oregon Oversight Agency. Next question. Is the Oregon legal model liable to principled extension? Why PAS only for the terminally ill? As Keown asks, what was the legal, much less the moral basis of a rule that grants the choice of one person but denies it to another because his or her disease wreaks its destruction more slowly? And we've heard from Dr. Lin the fascinating analysis of terminal and dwindling conditions. Why exclude all those many people with dwindling conditions who might not qualify as terminal? And why allow physician-assisted suicide but not voluntary euthanasia? Asked Keown. Was a person who's physically unable to obtain or administer his own lethal drugs any less deserving of the assistance needed to achieve a humane and dignified death? Why, one may add, isn't this unjust discrimination on the ground of disability? In the case of Myers and Schneiderman, in which the New York Court of Appeals recently rejected a right to physician-assisted suicide, one of the judges noted that the US Supreme Court had itself noted that what was couched as a limited right to PAS was likely a much broader license, which could prove extremely difficult to police and contain, and that the expansion from PAS to VE seemed, he said, all but inevitable. And a further question, once the law is changed to permit VAE, why not NVE? Why not non-voluntary euthanasia? Why deny incompetent patients who are suffering a merciful release? Remember, that's the question that Dr. Williams could not really answer when it was posed by Professor Camisar. What finally about the Dutch model? Does it ensure effective control? Well, it, like the Oregon model, relies on self-reporting. As Dr. Gorsuch asked, does a regime dependent on self-reporting by physicians who have no interest in recording any case falling outside the guidelines adequate protect against lives taken erroneously, mistakenly, or as a result of abuse or coercion? How, he asks, would we ever know? 6 comprehensive national surveys in the Netherlands have disclosed that since it was declared lawful in 1984, thousands of patients have been given lethal injections without their explicit request, and thousands of cases have not been reported by physicians. It's difficult to conclude, therefore, that the Dutch system, which has now twice been criticised by the UN Human Rights Committee, has been a model of effective control. After serving on one of the euthanasia review committees from 2005 to 14 and reviewing almost 4,000 cases, Professor Theo Boer's support for the law waned. In 2007, he'd taken the view that euthanasia did not need to involve a slide down a slippery slope, and that a good euthanasia law and review procedure could ensure a stable and relatively low number of cases. However, he said he'd been wrong, terribly wrong, and after 12 years' experience on of the Euthanasia Act, which had involved, he said, an explosive increase in numbers, he'd come to the conclusion some slopes truly are slippery. Interviewed in 2016, he said of about 45,000 cases of euthanasia and assisted suicide reported since 2002, only 75 had been referred by the review committees to the public prosecutor, and not a single case had resulted in prosecution. He commented that the system's reliance on self-reporting was a major flaw. Another concern was a shift in the type of patients seeking PAS and VAE. Whereas in the early years, the vast majority were terminally ill, an increasing number now sought death for dementia, psychiatric illness, and accumulated age-related complaints. And euthanasia is now accepted by the review committees, both in the early stages and in the later stages on the basis of an advanced directive. Something that not very long ago, leading defenders of Dutch euthanasia said was unethical and unfeasible. Initially, he said the law treated assisted dying as an exception, but public opinion was now beginning to interpret it as a right, with a corresponding duty for doctors to become involved in these deaths. It's safe to say, he said, that legalization has contributed to a normalization of physician-assisted dying and has led, due to its unavoidably flexible and ambiguous nature, to an expansion of its practice. He said, I'm convinced that supply creates demand. The supply of euthanasia, the availability of it, means that some people who would otherwise not have considered it now think, why not? 2/3 of accessing euthanasia, he said, would not have done so 10 years ago. There had been a paradigm shift from the doctor's duty of beneficence to the patient's right to self-determination. Doctors now said, basically, if a patient asks for euthanasia, who am I to question the unbearable suffering? Further, the independent role of the doctor, his or her own assessment of finding out what was unbearable or not behind the patient's request, had receded. The paradigm had shifted from an exception to a default, and for an increasing number of people, euthanasia is the best way to die, period. And there was a corresponding pressure on doctors. He said, the reality shows that once you have a law in place, the public, perhaps led by the euthanasia lobby, sees the law as a stepping stone towards an ever-widening practice. I was once convinced it was a respectful compromise between people of different opinions. But afterwards, it's just one step in a political play where the euthanasia lobby has much more drastic objectives. So don't be lured or misled by the rhetoric that this is a compromise. The ever-widening practice may soon be even wider. In 2016, the Dutch government announced its proposal to extend the law to allow assisted suicide for elderly people who may be healthy but feel their life is completed. Finally, Dutch courts have logically used the same justification they used to justify voluntary euthanasia, namely the doctor's duty to alleviate suffering, to declare non-voluntary euthanasia lawful in the case of disabled infants. Conclusion. The wording, interpretation and application of laws and the principles underlying those laws are at least as important to an understanding of the end-of-life landscape as statistical data, not least because whatever data are available may largely reflect changes in the laws or their interpretation. Thank you.